Hi guys. Okay. Thank you very much for watching the PowerPoint. So we're going to talk real quick about head, eyes, ears, nose, and throat. Not heavy content, nice review kind of for our neuro piece. Okay, so when we start looking at the head, we want to inspect it. We're kind of looking at the shape, okay? We tend to have this natural ability when we look at people to notice if their head is not the right shape, right? We want it to be nice and round and symmetric and appropriate for the body size, and we call that normocephalic. It's Normocephalic. Okay, and when we talk about an abnormally small head, this is one that kind of has come into the news a lot lately with our Zika virus, right? Our little babies that are born with these tiny little heads, they're called microcephalic. Okay, so microcephaly is a small head. The opposite end of the spectrum, if we have an abnormally large head, that's called macrocephaly. Normally the skull is symmetric and smooth, and there shouldn't be any pain with palpation. If we touch a patient's skull and it tends to be painful, then we start to wonder if they have shingles or some other sort of disorder that's affecting the skin of the skull. There shouldn't be a lot of pain below it with palpation, okay? We can palpate the temporal artery, so that's up here on the side of the head, right next to the eye, okay? Again, this is not a great artery where we're going to be able to pick up a pulse point or anything like that, but if you are looking at a patient and you start to see kind of this little pulsation here, that is the temporal artery, and you can pick up a little bit of a pulse there. The other thing that you can do is assess the temporomandibular joints, so if you put your hands here on your patient's chin and you ask them to, okay, and you're looking to feel the movement of the mandible from the maxilla, okay. We do look at hair distribution and for any lesions on the scalp that we might be concerned with. When we're looking at the face, it should be symmetric, okay, so the right side should equal the left side. If you look at our lady here, not a symmetric face, right? She has kind of a significant droop on the left side. The right side of her face. The left side is responding appropriately when she smiles, but if you look here, that's the right side of her face, because my right is my patient's left, okay? We shouldn't see any swelling. In our heart failure patients, for some reason, they get these funny little pockets right underneath their eyes, okay? And that's where they hold their fluid. Other areas that we might see swelling on the face, we might see some facial swelling down in this area if they have some dental issues. That's pretty much the two areas that we would see swelling unless there's some sort of injury. We're looking for the face to be proportionate to their body size. Some patients, their face will be very small, and in the center of, like their facial features are very small and in the center of their face. This woman happens to be very proportionate in her facial placement. This, again, is the facial droop, okay? We want to look for appropriate expressions. Are they flat? Are they happy? Are they manic? Where are they at on the spectrum, okay? And what sort of expressions are they putting out there for us? We're looking for any drainage, so that would be from the ears, the nose, the mouth, the eyes, anything like that. And we're looking for any signs of obvious distress. So if your patient is breathing funny, sometimes we will see this exhibited in their face. Okay, our subjective data, okay, we're asking for any visual difficulty. Are there any burning, any blind spots, any what we call floaters, okay, or decreased acuity, so decreased ability to be able to see. Do they have any pain? Okay, strabismus is cross-eyed, so when their eyes kind of go towards the center is strabismus, or actually exophthalmos is also strabismus, okay? So the eyes either deviate towards the center or they deviate towards the outside, and that's strabismus. Diplopia is a double vision, so they're seeing two of one object, okay? So when we hold up a finger and we ask a patient, how many fingers are we holding up? They should accurately be able to identify how many we are demonstrating for them. We ask about any redness or swelling that's new, any watering or discharge. Okay, watering is usually associated with seasonal allergies from the eyes. However, sometimes people will get a runny nose. That would be considered watering as well. We ask about a history of any ocular problems. So what's going on with the eyes? Do they have a history of macular degeneration or cataracts or anything like that? Okay, glaucoma is another concern that we ask about, and corrective lenses. Okay, when they have corrective lenses, we talk about, with the glasses. Do you wear them all the time? Do you wear them only when you need to read? Do you read them only for distance? What do you use the corrective lenses for? How long have you had them? We ask all sorts of things like, when was your last eye exam, if we have a concern that it's something that relates to the vision. Okay, when we look specifically at the eyes, okay, we want to see that direct reaction to light. So when our patients are, when we're testing our pupillary reaction, we want to see both the eye that we're testing as well as the opposite eye. Okay, that's called consensual light reaction. So if the right one shrinks, the left one should shrink equally as well, with the light being shined in the right eye. Okay. And again, this is checking for cranial nerves 2 and 3. When we check for convergence and accommodation, this is the end of that PERRLA, P-E-R-R-L-A. Okay, we're looking for the eyes to converge together. So you see very nicely here in this photograph, this person is demonstrating a beautiful convergence. Okay, the eyes converge towards the nose, and its accommodation is the piece where the eyes are trying to focus and maintain an adequate picture of what's coming towards their face. Okay, so when we do our extraocular eye movements and we're doing that nice H pattern and we're saying, okay, follow my finger. Okay, now I'm going to come at you. This is the accommodation piece and the convergence that we can finally document that PERRLA is intact. So our eyes are controlled by cranial nerves 2, 3, 4, and 6. Okay, again, 2, 3, 4, and 6. Please know the Roman numerals. Okay, it is not going to help you to write the what we call the Roman numeral, or the alphanumeric numbers. Okay, so looking at the eyes, 2 and 3 are our pupillary reaction. 3 controls our peripheral vision. So what's going on over here on the side of me? Okay, is, when I'm driving, am I able to see the cars that are coming out of my peripheral vision? So we can do specific tests for that, but PERRLA kind of pulls in both pieces of 2 and 3, so we're okay with that. Okay, 3 is also, remember, again, that thing with the cranial nerve man, it's the eyelashes. The cranial nerves help us to look, or cranial nerve 3 helps us to look up. Cranial nerve 4, we look for the nose, okay, and cranial nerve 6, we look out, okay. Common and concerning findings. Hyperopia is farsighted. That means they can see far away, but not close to them. Okay, presbyopia is the normal aging changes associated with vision changes. Myopia is nearsighted vision, so that they can read close to them, but they can't see far away. Scotomas are the floaters. These are the little like cloudy spots that people get in their eyes. Sometimes people will also talk about silver floaties, like silver confetti or something like that, that they see in their field of vision, and those are called scotomas. We already talked about diplopia, we talked about strabismus, any blurring of their eyes, okay? Eyes blur for a number of reasons. One is a stroke, they could be dry, there could be a foreign body or something in their eye that's causing the blurring, okay? Is there any redness or itching going on with them? Okay, discharge, we want to know what kind of color discharge it is. If it's a clear discharge, then it's very different than if it's a green or a yellow sort of sticky discharge. And then we start worrying about conjunctivitis, things like that. Eyes will hurt if they are in pain, okay? Foreign bodies will make people feel very uncomfortable just because that pain is so irritating in the eye. We ask about any excessive tearing, any swelling, okay? And it's not necessarily swelling of the eye itself, it's swelling of the surrounding tissues of the eye. We ask about any lesions, so are there any styes or hordeolums? If you read in your textbook in Bates, there's all sorts of different pictures there for you to review on eyes. Again, please don't try and memorize all of these. Just know that there are some differences. Please take the time to look at the chapter and see what's there. We also want to ask about visual disturbances, okay? So are they seeing things? Are they hallucinating? That also kind of falls in here. Are they seeing like shadows? What are they seeing when they're looking at people? Photophobia is light sensitivity, okay? Literally the light hurts the patient's eyes. It hurts their head. They just cannot deal with the light. They turn down the lights quite frequently so that they don't have to deal with the light. Pupillary abnormalities that we might see are anoscoria, and anoscoria are 2 different size pupils. So you might have one pupil that's maybe 2 or 3 millimeters, and then you might have another one that's like this big, okay? So anoscoria is 2 different sizes of pupils, and they usually do not react normally, or they lack reactivity, okay? Esotropia is when the eyes deviate towards the nose, okay? So if they're kind of cross-eyed towards their nose. Exotropia, they look away from their nose, so they're looking towards the outside. And this is a natural resting position for their eyes. This is not the little moment where, you or I try and cross our eyes just to be silly. Okay, so our testing for our eyes, we talk about PERLA, okay? Pupils are equal, round, reactive to light, and accommodation. We have our extraocular eye movements, and again, that is the H. Watch my finger with your eyes only. Don't move your head. Please hold it still. You can either move up in an H pattern, okay? And you're moving at a very, see if I can get more into the field of vision here. You're moving at a pace very slow so that the patient can see and follow exactly what's going on, okay? Over, okay? The speed that I'm moving at the video is about the speed that I'd like to see you moving with your patients, okay? You don't want to try and make them move so fast that they go dizzy. The other thing that you can do, if you're more inclined, if you like cat whiskers, you can do cat whiskers, okay? Instead of the H. I don't care how you do it, that's fine, but you need to assess cranial nerve 4, 6, and 3, okay? So you can do those. You can do the visual acuity chart. These are the Snellen charts, or what's called the Rosenbaum is the handheld chart that they hold up, okay? And this just asks them to read. Keep in mind that a patient's literacy level will also affect their visual acuity and their ability to complete the test. So if they can't read the letters, or if they can't interpret the letters and what they mean, they're not going to be successful with the Snellen chart. And then we use a Snellen chart that asks them to identify images. So there's a Snellen chart that's used for children, and for our lower literacy adults, it has boats and apples, and I can't remember all of the other pieces on there, but there's boats, apples, and like a ball, all sorts of different things that they should be able to identify the shape that they are looking at, okay? Peripheral fields of vision, we already talked about that. You can do things like assess your patient's field of vision by covering their eye, okay? And you come in from the side, and when do they see the bunny ears appear in their sight, okay? They should see it at the same time that you see it. If you go into your ATI book, your ATI videos, or you go into your Bates videos, they have a very nice demonstration of that for you. We want the eye movement to be very smooth. You don't want to see any of that, what we call that nystagmus, or that rhythmic beating. You want the eyes to be smooth and follow in the pattern, okay? If they start kind of doing this, 1 or 2 is okay, and then we want them to stop. If they continuously are kind of in this constant state of motion and their eyes almost look like they're beating, then we have concerns that there's some sort of issue going on. Okay, here's your reminder of what pupils equal, round, and reactive to light and accommodation are. You cannot document PERLA unless you test accommodation. So if you test your light reflex on the right and your light reflex on the left, you are only getting the pupils equal, round, reactive to light. You don't get that accommodation piece until you tell that patient, hey, I'm coming at your nose, and you're watching for them to cross their eyes and kind of focus in on their nose. Okay, so here's a nice example of the Snellen eye chart for you, okay? The normal individual is considered 20/20, and you have the patient stand 20 feet away from the sign, and they are able to read at the 20/20 line, okay? The first number, okay, so if we look at this 20, indicates what the patient can see at the second number, okay? So they see a 20 standing at 30 feet. Okay, so the larger the denominator, that's the bottom number, okay, the poorer the vision. So if you have a patient who has a vision of 20/30, they're seeing at 30 feet what the normal person sees at 20 feet, and their vision is worse than a 20/20. If you have a patient who has 20/60, their vision is considerably worse than the patient who is 20/20, okay? We always conduct this with any sort of corrective lenses in place. Okay, even if it's an eye injury, we do ask the patient to put their glasses on so that we can accurately assess their vision. Okay, we conduct first on both eyes. We ask them, please tell me what is the lowest number you can read. So if I were doing this, I'd say FELOPZD, and I'm reading line 7. Okay, then I'm going to ask them to cover up one eye, and I'm going to ask them if they can read the same line, F-E-L-O-P-Z-D, and then you ask them to do the same thing with the other eye, F-E-L-O-P-Z-D. Okay, you can ask them if you want to read a lower line. Okay, say, oh, that's great, you read line 7, can you read line 8 for me? Okay, do notice any hesitancy if they're squinting or if they're kind of leaning forward and they're like, okay. Notice what they're doing. Oh, okay. So near vision is what we conduct on a Rosenbaum chart, and it is literally the exact same thing, only it's a handheld card. It's about 14 inches in size. We hold it about 14 inches from their face, so a little over a foot apart, and then ask them to read it. Okay, so we have a nurse who's caring for a client who asked what her Snellen eye results mean. The patient's visual acuity is 20/30. Which of the following responses should the nurse make? Okay. Any answers here? I'm hoping you're all going with letter C. Your eyes see at 30 feet what a visually unimpaired eye can see at 20 feet, right? So letter C, because 20/30, they're seeing what the normal person sees at 20 feet, but they're seeing it at 30. Okay, in my little foxy cute here. Okay, so cranial nerve 8. Okay, or our ears. We ask our subjective data. Do you have any pain in your ears? Do you have recurrent infections? Is there anything leaking or oozing from your ears? Do you have any hearing loss? Okay, and again, the hearing loss that we have first is that high frequency hearing loss. When we lower the frequency, people tend to do better. Okay, we ask about excessive exposure to environmental noise. Do they operate a jackhammer? Do they work in a very loud setting like a bar where there's music playing all the time? The other environmental noise that I've started asking about a lot is kids, because they're wearing these earmuff headphones now when they're listening to their video games, and it's really causing some damage to their ears. So I do ask our younger population, and that even includes up into the 30s and 40s, we have gamers, okay, if they are exposed to environmental noise through their video games. Tinnitus or tinnitus, depends however you feel like pronouncing it, that is ringing in the ears. Vertigo. Okay, vertigo is that dizziness, if you think back to the neuro lecture when we talked about that. And that's what the patients describe as like the room's just spinning. It just feels like it's spinning and spinning, and they feel like they're almost gonna, like the room's just gonna turn on its side. Okay, this is very closely related to a vestibular imbalance in the ears. Okay, you can ask all the nice little patient-centered care questions like, when was your last hearing test? What is your method of cleaning your ears? And again, we should provide that education to the patient that you should not be cleaning your ears with anything smaller than your elbow. So our common or concerning findings: hearing loss as we get older. Okay, that can be a normal finding. Does it mean that we don't need to evaluate it? No, we do need to evaluate it. Okay, earaches, any discharge, any tinnitus, or any vertigo. Okay, so as a bedside nurse or a general practitioner type nurse, you are not expected to look inside an ear. So usually what we do is we start by inspecting the external ear. Okay, we're looking at the shape. We can feel it if we think that there's something abnormal. Most of the time it should not cause pain to palpation. Okay. We want to look at the size and the shape. Is it appropriate for their head size? Where does it sit? Do they have low-lying ears, okay, or high ears that are higher up on their head? We want to look for any skin conditions like flaking or redness or anything that might be occurring on the outside ear. Excessive warmness. Do keep in mind that wintertime is here. So when people put their headphones on or their earmuffs on, their ears will get a little warm to the touch. So think about environmental exposures at that point. We look for any inflammation or any swelling of the ear. Okay, this is called the pinna of the ear. We can examine for any scaling or crusts on the ear. Enlarged lymph nodes. There are lymph nodes that sit in front of our ear. There are lymph nodes that sit behind our ear. And the lymph nodes also drain all the way down here. Okay, from the ear. So any enlarged lymph nodes all the way along here would be concerning. Tenderness to the pinna. Okay, the pinna is the exterior ear. The tragus I'm going to get close is this really little tag here that kind of blocks up your hole. Okay, so you shouldn't have any pain when you push on the tragus. Okay, and we want to examine the external auditory meatus. So that is just the ear opening. Okay, a few nurses, ER nurses, were kind of different. We do actually look in patients' ears because we do end up with things like foreign bodies in ears. Okay, so this happens to be a bead in an ear. ER nurses will also participate in ear irrigation. I haven't heard if the ENT floor nurses look in ears or not, but I do know in ER we do actually look in ears. Okay, so for cranial nerve 8, how do we know that our ears are working? Good. If they're listening and following my commands, they're answering my questions, I can say that their hearing is intact and cranial nerve 8 is fine. Okay, cranial nerve number, what is the nose? One nose, right? So cranial nerve number 1 is the nose. We're looking for any discharge. Okay, so is it running? Are they bleeding? Do they have something clear coming out of their nose? Don't always be reassured by the fact that the fluid coming out of their nose is mucus. It could be CSF. Okay, so do ask what's coming out of their nose. Ask if they have frequent upper respiratory infections or colds. Sinus pain, okay? When you palpate a patient's face, if they have any pain either above their eyes, down here, underneath their eyes, along their nose, okay, then we get concerned for sinus pain. If there's been any recent trauma, okay, this seems to be one of our chief complaints with our facial problems. People have gotten hit in the nose, okay. Epistaxis is a nosebleed, okay. The most common site is an anterior nosebleed, which is the front of the nose. When we have an anterior nosebleed, the blood comes out the nose, okay? The old adage used to be that we told patients to pinch their nose and tilt their head back. But what we've realized is in doing that, we're taking all of that blood from the front of their nose and just sending it down into their digestive tract, and then they end up throwing up on us. So the new treatment now for an anterior nosebleed, blood that is coming out the front of the nose, we pinch the nose, we tilt the head forward, we hold the pressure on their nose. It is 10 minutes with no peeking. You have to tell them very specifically, no peeking for 10 minutes because we need that pressure on there, okay? Everybody wants to take off the tissue. No, it's still bleeding. No, 10 minutes, no peeking, okay? The other type of nosebleed that you can have is epistaxis of a posterior nosebleed. Okay, and those, what happens is the blood drains down the back of the throat. You won't actually see the bleeding, but the patients will tell you my mouth tastes really metallic. They might tell you I'm spitting blood. Anything like that, that would be concern for epistaxis. We ask about allergies or any altered sense of smell. Some people don't have a sense of smell anymore, which I think in nursing might be a blessing, but some people do have some altered sense of smells. Okay, looking at the nose, it should be symmetric and midline, middle of the face, right? Should be proportionate to the other features. You can test the patency of the nares if you're so inclined, pushing on one side and having them sniff. Do the same thing on the other side. Again, we don't often do this in terms of assessing the sense of smell. You can use the otoscope to gently look inside the nose. It should be nice and pink and moist, and it should almost look like the inside of the oral cavity. There shouldn't be any swelling, discharge, bleeding, or FB as a foreign body. We're looking for the septum to be midline, okay? Sometimes if you look up a patient's nose, you can literally see like the cartilage is almost twisted. So you'll look up the right side of their nose and you'll be like, wow, that just goes on forever. And you look up the left side of their nose and like you're seeing skin. That's all you're seeing. And that's a deviated septum, okay? All right, so sinuses. Here are where your sinuses all lie, okay? You palpate the sinuses for pain. You just take your thumbs and you push on their forehead, okay? And you do the same thing on the sides of their nose, okay? And this evaluates for a sinus infection, okay? We want to ask if they have any headaches, if they have any nasal discharge, or any upper respiratory infections. Okay, so here we go. We're looking at our mouth and our oral pharynx now. Our concerning signs or symptoms are a sore throat, chronic hoarseness. your baseline hoarseness that is associated with a sore throat is probably not as concerning as a patient who has like chronic hoarseness. Then we start getting concerned about cancer, okay? We look for any lesions or sores going on inside of their mouth. If they have a sore tongue, bleeding gums are definitely a concern of gingivitis. Any toothaches that they have, okay? Are their teeth in good repair? Are they showing a lot of dentition issues, or are they intact? And then dysphagia with Aegeas are swallowing, okay? Okay, so when we look inside the oral mucosa, okay, here's your tongue. You notice that you have all of the taste buds on the top of the tongue, okay? Underneath the tongue, it's very smooth. This is the hard palate. The soft palate is in the back. I'm sorry, the soft palate is back here. Hard palate is more in the front. When we ask our patients to say ah, right, and we open up the mouth real big, we're expecting the uvula to rise. This is cranial nerve 9, okay? 10, we check by testing a gag reflex. I'm not asking you to test any patient's gag reflex who is alert and oriented ×3 and awake and totally with it, okay? We test a gag reflex on a patient that is very severely compromised, and we need to know if they can manage their own airway, okay? What you're seeing here are the tonsillar pillars, okay? So if these are not always visible on a patient, if you look in the back of my throat, you can't see my tonsils unless I'm sick, okay? If you have a patient who has had their tonsils removed, you definitely will not see them, okay? If you do see them and there is what we call exudate, so like this white discharge on them, that becomes concerning for an infection. So our inspection of the mouth, we look at the lips for the color, the moisture, the cracking, or the lesions. Do keep in mind, again, it's wintertime, people are going to be chapped. We are looking for excessive chapped lips, okay? We look at the teeth and the gums. We do want them to be white-ish, okay? I'm so sorry, guys. Keep in mind that all of the teeth are stained by things like coffee and tea and sodas and all of the bad things that we drink for us. They should be reasonably straight, evenly spaced, clean, and free from debris and decay. You want the patient to bite down, and you want to look at the alignment of the teeth. How are they matching up? Okay, are they what we call end to end? Are they top over the bottom? Do they have an underbite where the bottom goes on top of the top? Okay, the gums should be really nice and tight and should stick around the teeth. Okay, you don't want to see these loose, flappy gums. That is not a good sign. They're more likely to lose their teeth if that's the case. The tongue should be nice and pink. The dorsal surface is rougher. Again, those are the taste buds. The ventral surface or underside of the tongue is the smooth side. You can use a gloved hand with a little 4x4 gauze to hold the tongue and look underneath the tongue at buccal surfaces if you are concerned that there is something going on. Okay, so again, pink and moist. This person is demonstrating a little bit of erythema in the back of their throat. You can see how it's red, a little bit more red where we're a little bit more pink here. The soft palate is more pale with rugae, and it gets darker as it goes back. We see this yellow discoloration of the hard palate in our darker skinned individuals in the roof of the mouth when they have jaundice. Okay, asking the patient to say ah, this causes the uvula to rise, which is example of excuse me, cranial nerve number 9 being intact. Okay, so when we look at the posterior oral pharynx, okay, we have the tonsils that should be the same color as the rest of the oral mucosa. They should be nice and pink, okay? We don't want to see any exudate or swelling. This is not a normal finding for tonsils, okay? These are abnormally large tonsils. We call these kissing tonsils because they are literally kissing each other, okay? It is a 4+, okay? 4+ is touching, 1+ is normal, okay? They should not be that large. You will test the gag reflex on a patient only if they are mentally altered, okay? A swollen airway, if we cannot get a breathing tube down, is a medical emergency and a very big concern, okay? Looking at the neck, we want to look for symmetry at the neck muscles, okay? Are they both equal on both sides? Cranial nerve 11 are the muscles that control the neck. We can check for range of motion. We want to be able to see if our patient can touch their chin to their chest. We can palpate the lymph nodes. We can check and make sure the tracheal is midline. Okay, so if the trachea is shifted, we see a couple things causing that. One, there's a pneumothorax. Okay, so there's extra air that's pushing the lungs and the trachea out of the way. We can see a mass that's pushing the trachea kind of off to the side. Okay, those are pretty much the two big things that'll cause a tracheal deviation. Okay. Palpation of the thyroid gland. I'm not going to teach you how to do it, but it does sit right here in the lower neck. Okay, you can inspect for JVD, and again, that was part of our cardiovascular assessment. So if you look at the anatomy and physiology of the neck, you have some muscles that run along here. Your carotid pulses sit in front of this, the sternocleidomastoid muscle. Okay. And that's where you should be able to feel them. If you feel your anterior chain of your lymph nodes, they follow the front of the sternocleidomastoid muscle there as well. Okay, so we have the anterior chain or anterior triangle here, and the posterior, what's supposed to be a triangle, doesn't look like much of a triangle to me, is there. Okay, just know that if we talk about a structure that it's in the anterior triangle, that's the location. In the posterior triangle, it's there. No, I will not test you on that. Okay, so our lymph nodes are part of the immune system. Again, review, their garbage collection system of the body. They drain towards the center of the body. So these are going to drain down. Okay, these will actually drain up in order to drain down. Okay, so towards the center of the body. There is a very specific order of assessment. If you'd like to learn the assessment order, you can look in your textbook. That is not something that I feel is relevant for a bedside nurse. Okay. Common or concerning findings, we get concerned if they're swollen, okay, or if there's any lumps or bumps, if their thyroid gland is enlarged, or again, if they have that chronic hoarseness. So what happens if we have an enlarged lymph node? What does it mean? Okay, usually means that there's some sort of infective process going on that we need to be concerned about, or a cancer. Okay, so when we do a lymph node assessment, okay, we're going to use a circular motion with the pads of our fingers. Okay, so you start here in front of the ears, okay, and then when you go back behind the ears, you can go here. Okay, you're just kind of going in a small little circular pattern. Okay, lymph nodes should normally not be palpable, so you shouldn't be able to say, oh yeah, that's a lymph node. Okay, if you feel a lymph node, that's probably not a normal finding. Okay, but if you do and it's soft and you can move it, so like you can push on it and it kind of moves over to the side, then that's a good thing. Okay, discrete means it's identifiable. We can pinch it and say, oh yep, there's only one there, and it shouldn't hurt. If we have lymphadenopathy, these are these enlarged lymph nodes that are greater than 1 centimeter. Our aging changes. Sometimes the eyes appear sunken because we lose that fat behind the eyeballs. Okay, the pupils do become smaller and they become kind of irregular in shape. We can see things like keyhole pupils, things like that coming on. Visual acuity decreases most progressively after 40 years. Everybody will tell you it's just about when I turned 40 that I lost the ability to read close to me. Okay, that is a very normal aging change. Okay, it's usually our near vision that that we lose first, and hence you see more people with reading glasses than you do with distance glasses. We can see development of cataracts, and that is the clouding of the eye, okay, where they are not able to see. Glaucoma and then macular degeneration are both changes that happen within the eye that alter the fields of vision. We have hearing that decreases with age. We talked about presbycusis already. There is decreased saliva and taste, so a lot of times older adults will add a lot of spices to their food in order to be able to get the taste to where they're used to it being. And they also will say that they're thirsty a lot and their mouth just feels dry because everything dries up as you get older. Okay, and the teeth become more worn down, and a lot of people do lose their teeth as they get older, and then we replace them with dentures or partials as needed. Okay, guys, that is the end of it. Thanks so much. I hope you all have a wonderful weekend.